stems from interruption of the gag reflex. That's why we confirm that the client hasn't had anything to eat or drink for the last 8 hours. If medications are prescribed to sedate the client or to dry secretions, that would usually be atropine. The nurse administers them. During the procedure, the client is positioned in semi-Fowlers or Fowlers. The nurse assists the physician as necessary and monitors the client's respiratory status. After the procedure, the most important nursing activity is to protect the client from aspiration. The nurse checks for the return of a gag reflex and makes sure the client has nothing by mouth until it has returned. The nurse also monitors for signs of respiratory distress and bleeding, and watches for more serious complications such as pneumothorax and perforation. And throughout the time the client is here, it is important to provide emotional support and to allay anxiety and fear. Our next client is going to have a thoracentesis. That means he is here to have fluid removed from his lung, secondary to lung cancer. He has had this done several times before. The thoracentesis, although painful, helps relieve his respiratory distress. The nurse who assists with this procedure performs the usual pre-procedure activities, helps with the procedure, and then monitors the client afterwards. For example, the nurse will auscultate lung sounds, make sure a chest X-ray is done to check for pneumothorax, and observe the client for tachycardia, respiratory distress, cough, and secretions. For the actual procedure, the nurse will have the client lean forward on a padded overbed table. The nurse will explain that the doctor will be cleaning his skin with an antiseptic that might feel very cold. Then he will insert the needle. The nurse will remind the client that it is important to remain still, without talking or coughing. Then the nurse will check the client's tolerance by asking something as simple as, "Are you doing okay?" After the procedure, the nurse will make sure that the occlusive dressing is intact. Position the client on the unaffected side for at least 1 hour or supine with head of the bed elevated. Measure and record the fluid removed and send it to the laboratory and monitor the client for any complications, such as shock, pneumothorax, bleeding, subcutaneous emphysema. Before the client leaves, she will review the signs and symptoms of infection. Of course, it is critical to monitor vital signs and watch for signs of respiratory distress. We've gone through a lot of information here, and you may have some questions at this point. One that has popped into my mind is, do you ever inject chemotherapy agents into the pleural space? And the answer is yes. Sometimes, if metastasis is present, we will do this. And what else besides pulmonary procedures are done at the pulmonary function lab? At the lab, we also run arterial blood gas analyses, and the respiratory therapists help manage our clients who use oxygen at home. The basics of arterial blood gas analysis. ABGs are diagnostic tests that determine the amount of oxygen and carbon dioxide in arterial blood. ABGs provide an indicator of the acid-base state. ABGs tell us how well oxygen is carried in the blood. The blood's pH, or potential of hydrogen, is its acidity or alkalinity. It reflects the hydrogen ion concentration of the solution. The normal pH range for blood is 7.35 to 7.45. It's easy to think of it as a seesaw. As pH decreases, blood becomes more acidic, and as pH increases, blood becomes more alkaline. PaCO2, or PCO2, reflects the partial pressure of carbon dioxide with a normal range of 35 to 45 millimeters of mercury. PaO2, or PO2, reflects the partial pressure of oxygen, with a normal range of 80 to 100 millimeters of mercury. Think of it as gas in a liquid. CO2 is a potential acid, meaning that it becomes an acid, specifically carbonic acid, when it is dissolved in water and a small amount of it does dissolve in water in the bloodstream. So it can help buffer an excess of bicarbonate ions, or HCO3, which are, of course, alkaline. HCO3, a measure of bicarbonate ions, has a normal range of 22 to 26 milliequivalents per liter. Base excess, or BE, a calculated value of bicarbonate levels that reflects the metabolic component of acid-base balance, has a normal range of -2 to +2 milliequivalents per liter. Base excess will be low with metabolic acidosis and high with metabolic alkalosis. Bicarbonate ions can help buffer excess acidity. SaO2 is oxygen saturation, or how much oxygen is bound to hemoglobin. The normal SaO2 range is 96 to 98%. Think of this as a measurement of how efficiently the client's bloodstream is carrying and transporting oxygen. So, just when is an arterial blood gas analysis indicated? Whenever a client has acute or chronic illness, trauma, fever, dehydration, fluid and electrolyte disturbances, sepsis, or shock, as well as during and after CPR. Arterial blood gas analysis requires arterial blood sampling. The radial artery is the usual source, but blood from the femoral artery or from an arterial line already in place are also possibilities. The clinician will heparinize the syringe to keep the blood sample from clotting. The sample must be transported on ice to the lab immediately. If the puncture site is not an arterial line, pressure must be applied to it for 10 to 15 minutes and then a pressure dressing applied firmly. Now for interpreting the results. First you'll check the pH to see if the problem is acidosis or alkalosis. If the pH is below 7.35, it's acidosis. If it is above 7.45, it's alkalosis. If it is between those two, it is normal. Step 2 of your interpretation is to determine whether the disorder is respiratory or metabolic. PCO2 is the indicator for respiratory, and HCO3 is the indicator for metabolic. If the pH is low, meaning acidic, and PCO2 is high, remember it's an acid, the disorder is respiratory acidosis. If the pH is